Welcome to the second webinar in our series, Saving Lives with Autotransfusion, Lessons from the Field. It's a CSU Global webinar series where clinicians speak about their experiences using Hemafuse in surgery and other global health issues. Today, our webinar chairman will be Dr. Chris Fofie. Dr. Fofie is a consultant obstetrician and gynecologist and is the head of Safe Motherhood Project at the Ghana Health Service. So I'd like to welcome Dr. Chris Fofie.
Thank you very much. Yes, you are all welcome to this program, and I'll start by saying thank you very much to you and the organizers for this program for inviting me or accepting me to chair this program. So, as you all know, this is a very important topic, especially to our context in Ghana, where we still have very high levels of maternal mortality attributable to hemorrhage, and issues with a bit of a challenge. So without delaying much time, I will go further to give a quick overview of the program that we'll be having today. To start with, we intend to really give you a very good understanding of what is going to happen here. And the first on the list is going to be a presentation on anemia, the management and prevention of anemia, and that will be done by Dr. Sylvia Deganus. Straight away, there are other presenters that are coming to make this an important occasion. And the next, apart from Dr. Deganus, we'll be having Dr. Asma Awad, who is a physician, public health specialist, also coming in as a trainer of trainer with CSU Global. She has vast experience in training of Hemafuse globally, and when it comes to Kenya specifically, she's done a lot of work there. So we're going to have her presenting to us a demonstration on the use of Hemafuse, and we should stay glued to see how that will come in. The next presenter, who is a special person to us, is Dr. Gerald Osei-Owusu. This another medical officer with Tema General Hospital who has done quite a great work. I mean, unlike so many other young people who wait to see the seniors take the initiative before they join, this is somebody who has taken the bull by the horn, practiced already with the Hemafuse, and generated his own evidence, which he'll be sharing with us. That's a fascinating work, and we'll be happy to see that. So that's also on the way. And don't wait, there is still more to come. We have another presenter, that is Mr. Fred Anim, who is working with the Jehovah's Witness Liaison Committee, and we know already the issues that come along with medical and ethical issues relating to blood transfusion and donation and all that. So he will be taking us through.
And I'll be discussing the prevention and management of anemia in pregnancy, and perhaps sharing some of the experiences I've had working as an obstetrician in Ghana. My presentation will look at what we mean by anemia in pregnancy. We'll discuss the extent of the problem and the effects in pregnancy on the mother and child. We'll look at the causes, and we'll look at how to recognize anemia. Then we'll move on to the prevention of anemia in pregnancy, and then discuss the management of women with anemia in pregnancy. We'll touch on anemia in some special risk groups like sickle cell anemia and women with HIV, and after which I'll end my presentation and look forward to questions from you all. So let's start off with looking at the definition of anemia in pregnancy. According to WHO, anemia in pregnancy should be diagnosed if a woman's hemoglobin concentration is found to be less than 11 grams per deciliter. We can also further group this into two groups: women with moderate anemia and women with severe anemia. Moderate anemia is where the hemoglobin is between 8 to 11 grams per deciliter, and severe anemia is when you have hemoglobins of less than 7 grams per deciliter. Now, looking at the extent of the problem, anemia is the most common health disorder worldwide affecting pregnant women. And according to world estimates, we have about 42% of pregnant women in the world being anemic. In sub-Saharan Africa, the prevalence is thought to be much higher at about 50%. Now, this graph just shows a very recent survey we did looking at anemia in pregnancy in about 40 African countries in the region. And you can see the extent of the problem. It ranged from less than 1% in Zanzibar to over 70% in Burkina Faso. So really we have a big problem. Ghana is somewhere in the middle, as you can see, with about a 43% prevalence rate. Now, anemia and other nutritional deficiencies are quite common in Ghana. And this chart just shows you a map showing the prevalence of anemia and iron deficiency in general, and also other vitamin deficiencies. You don't need to bother about the others. But just to show you that anemia is a problem that affects both pregnant women and also young children in Ghana. And it tends to be more predominant, especially in the upper parts region of the country, where we have the darker shadows, as you can see from this chart. And indeed, about 76% of women generally suffer anemia in Ghana. And most of it is iron deficiency anemia. I just looked at and saw a recent study done in 2019 involving 400 pregnant women who were receiving antenatal care in Tamale, and about 50% were anemic. The interesting thing is, even at the end of the third trimester, there was still anemia in pregnancy. So it's really a big issue in this country. This chart also shows the prevalence of anemia over a 4-year period. I was trying to look for the latest chart, but I didn't find this. But what is interesting is that look at the prevalence of anemia at booking, and then look at the chart of anemia at 36 weeks. And Ghana is one of the countries touted to have a very good antenatal coverage rate, and 4+ visits is one of the highest in the region. So to imagine that even though these women are coming with anemia and we are detecting that almost a third of them, that's 33% are having anemia, at the end of the antenatal period at 36 weeks, we are still finding about a quarter to a third of women still anemic. And that should raise questions about what we are doing to prevent anemia in these women. Now, what are the effects of anemia in pregnancy? Anemia in pregnancy has consequences both for the mother and her baby. For the baby, it's associated with increased risk of low birth weights, premature delivery, and higher rates of perinatal mortality. For the mother, anemia is associated with poor maternal well-being. She's generally not healthy. She has low energy. She's also more susceptible to infections, and more importantly, has an increased rate of death from all the major obstetric complications, and especially PPH. Indeed, it's been shown that for every 20% decrease, or for every 1 gram per deciliter decrease in hemoglobin, you have a 20% increase in maternal death. So your risk of maternal death increases for every 1 gram drop you have in your hemoglobin level. So it's very important to correct hemoglobin defects in pregnancy. Now, what are the causes of anemia in pregnancy in our region? Indeed, I could group them into 2 groups. Women, you can have anemia due to inadequate red blood cell production, or you can have anemia due to increased loss. Now, in our region, inadequate red blood cell production is one of the leading causes, iron deficiency and other raw material deficiencies like folate and B12. Occasionally, we have the bone marrow failures, so you shouldn't forget that. We have women with chronic disease where generally they are not able to sustain adequate intake and therefore adequate red blood cell production. And then we can look at those conditions associated with increased loss. whole blood loss due to bleeding and infestations like hookworms and schistosomiasis and so on. Then we have, more importantly, those anemias associated with hemolysis, where we have excessive breakdown of red blood cells within the body. So the sickle cell anemias, the women with G6PD defect, malaria, and hyperactive splenomegaly issues. So those cause, but in our region, what is important to note is most of anemia is multifactorial, and most of it has to do with inadequate intake of the raw materials. So having talked about the causes, now we need to talk about how do we diagnose anemia in pregnancy. The rule is that every single pregnant woman must be screened for anemia, and also, whilst you're at it, screen for the underlying causes. Screening starts with history, asking about all the symptoms of anemia, easy fatigue, dizziness, palpitations, shortness of breath, feet swelling, and so on. These are well known to many of us. So do we actually ask our women when they come about all these symptoms at each visit? Then next, we also have to examine them for anemia. Look at pallor of the palm, sole of the feet, and the mucous membranes. In my experience, I find the tongue perhaps better than the inner eyelid. I don't know, but that's what I find very informative when I'm looking at anemia. But then you can also find other symptoms when it's swell. We could look at the cardiovascular system, but maybe for the purpose of today, we won't go into too much detail. Then we can look at laboratory testing. Every pregnant woman is supposed to have her hemoglobins checked at booking. That's whenever she comes in for the first visit, at 28 weeks and at 36 weeks. That is, even if she's well and she has no symptoms, they must have at least hemoglobin checked at these 3 moments in their pregnancy. And then, of course, when you check the hemoglobin, you determine whether they have moderate anemia or severe anemia. At this point, let me say that in our setting is that when the you find out that very often somebody's playing. You find out that a red circle is put around the hemoglobin level by the attending midwives who see the client, but they don't often use the term anemia. Whenever the hemoglobin level is less than 11 grams per deciliter, you already have a diagnosis. You don't need to put a circle around it. You just have to state what is obvious, and that the woman has anemia in pregnancy, and define it if it's moderate or severe. Now, we have various methods, but what WHO recognizes that the best option is to do the full blood count, not just order for a check HB. Do the full blood count, and that is more informative than having just done the check HB. But in settings where full blood count testing is not available, then we can limit ourselves to doing just the hemoglobin and at best with the hemoglobinometer. So a full blood count is what is recommended, and not just the HB test, which very often is done by most people. Having diagnosed anemia, let's look at preventing it first. How do we prevent anemia in pregnancy? WHO recommends iron and folate supplementation even when women do not have anemia at all. If you see them and they have no anemia, you are supposed to supplement them with iron and folate, simply because pregnancy increases demand for these micronutrients, as the mother and baby both have to form red blood cells. And so if you do not give them the supplement, then you are likely to push their hemoglobin levels down if they are not taking adequate levels. Now, to supplement them, oral iron 60 milligrams and folic acid 0.4 milligrams is what is recommended to prevent anemia. So in this country, we are giving probably 5 milligrams, and then what I have observed is that Ghana recommends 60 milligrams, but you find that in our clinical settings, a lot of things are going on, and perhaps explains why women still remain anemic even in their 3rd trimester. when there is the 60 milligrams is what is recommended in settings where we have at least 40% of our pregnant women having anemia. So that's what is recommended for Ghana. You can give lower doses in places where you do not have anemia as a public health issue. And I want to mention here that ferrous sulfate which is what is recommended by our government, contains 60 milligrams of elemental iron. But if you choose to use other preparations, then you have to give them the requisite dosage. For example, you need to give 180 milligrams of ferrous fumarate in order to be able to get your 60 milligrams of elemental iron, or 500 milligrams of ferrous gluconate to be able to achieve the 60 milligrams of elemental iron. With folic acid, it's best to start as early as possible, even ideally before conception, in order to prevent neural tube defects. So that is iron and folic supplementation. And I just want to present here an alternative regime. And this is for situations where you cannot, daily iron is not acceptable due to side effects, or in settings, or like you have a very elitist woman where she's likely to be eating good diets and therefore not likely to have anemia. You can choose to have intermittent iron folate supplementation. So you give 120 milligrams of elemental iron with 2.8 micrograms of folic acid, just one weekly. And that is all you need. So people who have poor intake or poor absorption and have challenges, you still have the option of giving them a once weekly dose of iron and folic if they cannot take it daily. I just want to present this slide here. And just to show you some of the common preparations that are being taken by pregnant women in Ghana. And the question I choose to ask is that how much iron and folate do these contain? A lot of us prescribe these things without recognizing their doses. This is just without prejudice to the companies, because they provide these preparations and we, the clinicians, are supposed to know what we are giving. For example, one of the preparations listed has just 17 milligrams of iron. And so if you choose to prescribe this for your woman, then you need to top it up to 60 milligrams. So the question we ask is, how much iron and folate do these contain? And you need to ask yourself, do they meet the dosage requirements for pregnant women? And I'll leave this to us to discuss at the end of the preparation, of the presentation. We also need to talk about food, nutrition counseling. Foods can help prevent anemia, and we need to have information on locally available foods which are rich in iron and the folate and sometimes the other vitamins. And I'm going to show, just before I move on, I just want to talk about also the foods that inhibit iron absorption. Many of us tell our patients, please take your medications after your morning breakfast. And sometimes the morning breakfast is a cup of tea, coffee, or some may choose to have other foods. Some of these foods can inhibit iron absorption. So you are literally doing no work. You take your morning tea, a cup of tea, and swallow your iron tablet with it. Forget about absorbing any iron. So we need to discuss these issues when we're also doing nutrition counseling. Another practice is clay chewing by a lot of our pregnant women. This is known to be associated with iron deficiency because iron deficiency promotes pica. Pica is when people choose to eat all these unhealthy foods. And clay is something that's commonly eaten by our pregnant women for various reasons. But it may be also because these women have iron deficiency and therefore that pica is being provoked. So we need to think about that. So this is just a slide to show you all the various iron-rich foods. Ghana has a lot of iron-rich foods that we can encourage our women to eat. Their local foods. There's turkey berry or kweosusua, the crabs, shellfish, anchovies, dried fruits, all these mangoes, avocados. We need not tell them to go and buy huge boxes of everything. They are available, the ampesi with the akontomire. These are foods that our women can eat to help enrich their diet and improve their iron intake and folate intake. Now, other preventive measures are also recommended. It's not just food and iron supplementation. We also need to look at the issues that are associated with a lot of red blood cell loss or increased red cell destruction, which are quite prevalent in our populations, especially malaria and the helminthic infections. So one of the things that, or some of the things that WHO promotes is preventive treatment for these conditions. And one is to deworm our population, our pregnant women. A single dose of albendazole or mebendazole is recommended after the 3rd trimester in settings where we have helminthic infections in 20% of more of our population. And that is a situation we find ourselves in Ghana. Some women have little zoos in their stomach, and so you need to cleanse it all out with just a single dose of these medications. And as I've shown up, it's 400 milligrams of albendazole or 500 milligrams of mebendazole, and these are readily available. The next one is also malaria treatment, and in Ghana falls within the endemic zone of where we have malaria. And so sulfadoxine pyrimethamine is recommended for all women. They are to start in the 2nd trimester and take monthly doses and are expected to have at least 3 doses. Generally, we leave these to the midwives to take care of, but we need to remember as doctors and all care practitioners that we must ensure that our women take these medication. Malaria is a serious problem in pregnancy and has been associated strongly with anemia. And this is simply because the placenta acts as another zone for parasitemia development. And so this is important in managing anemia in pregnancy. I just want to highlight what is not recommended here in our preventive therapy. Multiple micronutrient supplementation. And just to tell the story, just last week I saw a woman who was on pregnant care, Vitafol, folic acid, and then what? I think Eleron. And this is simply not acceptable. She does not need all those medications. And when that happens, they just abandon all the medications. So we need to be careful. Micronutrient supplementation is not recommended. Vitamin B6 supplementation not recommended. Vitamin E, vitamin C, vitamin D, these are not recommended in pregnancy by WHO. Many of them have side effects. So when we give multiple medications, sometimes containing this, then we are doing the wrong thing for our clients. So now let's move on to the last bit, which is managing the pregnant women with anemia. So now we have diagnosed anemia. We are no longer preventing. We only prevent for those who do not have anemia. But when we have diagnosed anemia in pregnancy, then we need to manage the woman differently. There are 3 issues we must take into consideration when we are developing the care plan for that woman. Her gestational age at the time we are making the diagnosis, the severity of the anemia at the time, and the underlying causes. What is causing that anemia? Now, to just discuss this, when we talk about gestational age, the principle is that no pregnant woman should enter labor with anemia. So the shorter the duration to her expected time of delivery, the less time we have available to correct that anemia. So if we have a short time, it means we must be more aggressive. It means we must also take some urgent measures such as blood transfusion, because we do not want any pregnant woman entering labor with anemia. That doubles and quadruples her risk for death from postpartum hemorrhage. Now, looking at the severity of the anemia, obviously, any severe or symptomatic anemia in pregnancy at any gestational age is life-threatening and should be managed urgently, and especially with admission to hospital and blood transfusion. So the severity is very important, irrespective of the time of the gestation. The last consideration to look at is the underlying cause. And this means that we need to determine the cause of the anemia through history, physical examination, and our laboratory tests. So please take a look at our urine test. What do they say? The stool examinations, do we really look at it? The full blood count, that tells, and then the blood picture. We need to find out what is underlying this woman's cause of the anemia, especially, and very especially if we want to move forward. Is it sickle cell, G6PD, iron or B12 deficiency? And even sometimes more specialized tests are needed to determine the cause. But these three considerations influence how we manage the pregnant woman. So I just put up this simple flow chart for us to look at. So we do our first assessment and we determine that the woman has anemia. And we also look at the underlying causes. We have said that if the anemia is severe, that's less than 7 grams per deciliter, then we need to be, irrespective of the gestation, that woman has to be managed in hospital and more aggressively. She must be admitted and the underlying cause must be found. And if she's near delivery, then we have no choice. And if she's symptomatic, then we also have no choice. She will require blood transfusion. However, when we consider the group within hemoglobin of 8 to 11, those with moderate anemia, then we have to look at the duration, the time duration. And here, we need to double the dose of the elemental iron. And it's no longer 60 milligrams, it's 120 daily. You need 2 tablets of ferrous sulfate to treat. We are now treating, we are not preventing. And then we also need to have our folic acid, 0.5 milligrams daily. We also need to make sure that all the underlying causes are treated. And we need to monitor that woman very frequently.
Doctor.
I got a message, I'm being muted. Can you hear me, please?
Yes. Yes.
Okay, so I'll go on. So you need to monitor the hemoglobin at all visits until it's normal. And you also need to monitor the fetal growth closely because you remember we have effects of this anemia on the pregnancy. So you treat anemia with double dose of iron, folic acid. You look for and treat all the underlying causes, and then you need to monitor and increase your visit. It can no longer be just a routine visit, especially in the first 2 to 4 weeks after you initiate treatment. Is there any sign that this woman is receiving or taking the doses as required? Is the hemoglobin like going up? Or are there signs? You need to see this woman frequently. Unfortunately, most of us do not do this. It looks like my slide is frozen. Can you see the next slide?
No, please.
No. Yeah, I'm moving the next slide. Oh, okay, now I got it. Now it's here, so we can go on.
Yeah, you can go.
So, yes, I have it up.
Treating anemia in pregnancy.
Yes, in pregnancy. So, like I said, we need to increase your iron dose, and then you need to continue with that higher iron dose until her hemoglobin rises to normal. So you can only move her to the supplementary dose only after her hemoglobin has been corrected. Okay. Then you can move her to the standard dose. Other than that, you need to double the iron intake. And like I said, you need to check the hemoglobin levels more frequently, especially within 2 to 4 weeks after initiating treatment. And you need to continue to encourage this woman, work with her, let her know. Most of us forget to inform the woman and encourage her and say, look, you are doing so well. Your hemoglobin is now increased from 8 is now 9. Whatever you are doing such an excellent job. go ahead and continue. And the more you encourage her and get her engaged and involved in the process, the more likely you are to succeed. And remind her that we have to get that hemoglobin to higher than 11 before she's due to deliver. And this is very important. And at this point, I will just touch on a little bit about blood transfusion for severe anemia in pregnancy. It is indicated if severe anemia is occurring in the 3rd trimester, you have no choice. And especially if it's accompanied by symptoms, we cannot get that woman to enter into labor with severe anemia. So that has to be done. It's also important to recognize that if severe anemia is occurring in the early pregnancy, you might, if you're a little more experienced, look at not just the hemoglobin value, but also look at the symptoms. If you think that your woman can cooperate and she's asymptomatic, then you may choose to, and there is time. Remember, the 3rd consideration, time. You may choose to start her on hematinics to relieve symptoms. So blood transfusion should be prescribed only when the benefits outweigh the risk. And this is very, very important in management of anemia in pregnancy. Let me just touch on here on anemia in special risk groups, like the pregnant woman with HIV infection or sickle cell anemia and G6PD. These constitute special high-risk groups. What I would like to say is that, please, these women must be managed in hospital by doctors who have skills and who can manage the anemia. We can't go into the details here, but with sickle cell and with HIV, you may need to adjust their medications because some of the medications are contraindicated for women with anemia in pregnancy. It worsens the situation. With sickle cell anemia, you also have to look a little further at looking at the iron levels before you prescribe medication. So it's best to manage these people, get them somebody who is experienced, let them be managed in hospital. For sickle cell anemia, you would give your 5 milligrams of iron. And it's best like this. Normally, they have started it preconceptually, and you must maintain that high dose throughout pregnancy. But iron supplementation should be given only if there is laboratory evidence of iron deficiency. I'm informed. I remember my teachers used to say that, look, even in this setting, our women with sickle cell anemia are still iron deficient. So I tend to give them treatment with iron, at least the prophylactic dose. But if you are in a setting where you can check the iron levels, it's best to check this before you provide them with iron. So I'd like to end my presentation here. We have other presentations by concluding the following: that anemia of all degrees during pregnancy is associated with serious health consequences for mother and baby, and it's nothing we should joke about. The causes of anemia are multifactorial here. For preventing anemia, we need to give iron folate supplementation, malaria treatment, and deworming of our women, and don't forget nutrition counseling. Whether they are symptomatic or not, every pregnant woman must be screened. And so for those who have anemia, there are 3 considerations you must make when you are managing them. Their gestational age at the time of diagnosis, the severity of the anemia, and the underlying cause. Remember the principle that no pregnant woman must enter labor with anemia. So our goal is to get their hemoglobin levels to 11 grams or more before labor. And remember that there are some high-risk anemia, women with anemia, those with HIV, sickle cell, and G6PD, and they must be managed at hospital level by doctors with relevant skills. I just have a few references up, and I want to say thank you for your attention. And at this point, I would ask for your quiz, and I just want to raise the awareness that if we are doing such a wonderful job for anemia in pregnancy, why do we still have a huge chunk of our women remaining anemic at the end of their pregnancies? We should not have that. It means that we are failing our pregnant women. We are not achieving the results And therefore, we need to take a special look at what we are doing in the management and control of anemia in pregnancy. Thank you once again for your attention, and I will end my presentation here.
This is a brilliant presentation by Dr. Deganus, and despite the initial hitches, we'll go ahead full vim and hope to achieve our objectives. I will go further to have the presentation or the demonstration from Dr. Asma Awad. So thank you very much. Is Dr. Awad ready, please?
Thank you, Dr. Fofie. My name is Dr. Asma Awad. Good afternoon, all. Before I go to the demonstration, I just want to give a brief narrative. Hemafuse is a medical device that operates on the idea your own blood is better than someone else's blood. In operative cases of internal bleeding, Hemafuse can capture blood, filter that particular blood, and give it back to the same patient. In Kenya, Hemafuse has been used across in different hospitals, and we have different surgical fields. For instance, we have use of Hemafuse in ruptured ectopic within the OBGYN team. We have use of Hemafuse in the orthopedic team where we had hip replacements and the use of captured blood. And then we also have in the surgical where we have ruptured spleen and some of the cardiovascular surgery like repairment of the aortic aneurysm. So I will go into demonstration to actually demonstrate how to assemble Hemafuse and how to operate the device itself. So with me, I have the first part is the pump. So we have the 4 parts of the pump, which I will assemble. These are reusable up to 25 times, and they are autoclavable. So we have the plunger, the O-ring, where you can fix the O-ring on the plunger. Then you put the plunger into the barrel all the way. We do have a filter that has a one-way valve, and it has a microparticle filtration system. So we put the filter on the barrel, and then we put the nozzle. So the filter comes already sterile, pre-packed, and it is single use, and you need to discard it immediately after use. So the pump with the filter is ready. So I will put the inlet accessory. So we have the inlet accessory, which also come pre-packed, already sterile, and they're the ones that we use them to collect the blood from the surgical sites. We have the anchor tip. We have the suction connector, which is connected to the anchor tip, and then we have a short tubing. This one mostly helps you, especially when you're trying to maneuver and to collect all the blood in your surgical field where you are seeing it. So this is the inlet kit or the inlet accessory, which I said they're single use, come already pre-packed in a sterile pack. Then you connect your small tubing to the opening at the nozzle and ensure it is well connected, so we don't have any accident during the operation of the device. As you can see, we have the pump ready and the inlet accessory as well ready in connection of the device. Can everyone see the demonstration? We do have an outlet accessory, and these allow you to push the blood that you have collected in your barrel to go to the blood bag. So we have the long tubing, and the long tubing comes directly, and there's an opening at the barrel that allow you to push the blood that has been collected into the pump to go to the blood bag. So you put the tubing, ensure it is well fitted. Then now we do have a stopcock connector, and we have a spike. So this you need to ensure you put them in a straight line. So we'll have our spike. The spike goes to the blood bag, and then we have the stopcock connector that connects the stopcock, and you have your stopcock kit already ready. This part of the stopcock that's written stop allow you to navigate and move the blood to different sides. If you want to prime or remove any air that has been collected in the system, or if you want to push your blood to go to the blood bank. So with this, you will put the kits at the end with the long tubing, and then I'm having a demonstration bag. This is not a standard blood transfusion bag, but we'll assume it is a standard blood transfusion bag. That's an assumption. So this one will fix at the spike to allow you to move your blood from the pump through the outlet kits into the bag. So my pump is ready. I am having my pump assembled, the inlet accessory assembled, and the outlet accessory assembled. That allows me to collect the blood from the patient into the pump and out of the pump to the blood bag, and then I can use the blood bag and transfuse the blood. I want to quickly demonstrate how to operate the device. In ideal setup, I'm not here, I don't have an ideal setup on my table, but in ideal setup, we should have a minimum of 3 surgical team members to actually use and operate the device. So we have somebody who will be operating the anchor tip, we have somebody who will be operating the plunger, and we have somebody who will be operating or managing the blood. So you at least have a minimum of 3 people. I do have a pretend blood pool in my bowel here. This is just color dye. So what I'll do, what I tell most of the surgical team using the device, you need to do active management of clots. And in active management of clots, you can either wrap the anchor tip with a sterile gauze so that when you have clots coming in, they do not clog up your anchor tip and it doesn't make it hard for you to actually collect your blood. So we'll have our anchor tip. So the member who is there first will ensure this is fully submerged into the system. So once it's submerged, and then you will actually just pull. So as you can see, there is some blood going in, or we have some fluid going into the system, and you continue actually pulling it. One other thing you'll notice, we have a lot of collection of air, and we can actually have priming or removing of this air by slightly turning the nozzle on the barrel to press up and give preference to air to go up and water to go down. That's the rule of physics. And then you inform the person who is managing the bag to close the bag so that nothing goes in or no air is introduced into the bag, and slightly push, allowing that air to come out. So once you are happy,
Dr. Asma, can you just you're just right at the top of your screen. Can you just reorient a little bit? Perfect, just like that.
Cool. So once you have removed all the air from your system, you tell and you find that if you have more blood on the other side, you can continue pulling more blood into the system. And then if you feel you've collected enough in the barrel, you can always tell the person on the other side. So we open to the bag to allow blood to go into the system, and the person who is managing the bag will be rocking the bag as I push the blood to go into the So here we've opened the bag, so we'll allow the blood to be pushed inside. So you can see the blood is actually going into the blood bag. Whoever is managing here will be rocking the bag to allow mixing of this blood with the anticoagulant. So we gently push completely, having the blood going in. Once you have enough, you can now just take the blood bag. Once you have this enough, you can take the blood and start giving it to your client during the procedure. You don't need to wait for any other time. Tim, I think that's all. So it is quite a simple assembly and operation of the device, where you can quickly assemble it and use this particular device to actually give blood to your patient and give it during the same surgical procedure. Over to you, Dr. Fofie.
Thank you very much, Dr. Asma. From concept, we've now seen the practical aspect of it. All those who had it as an imagination can now visualize it and understand it better. Thank you very much. All right, so we move further now to Tema General Hospital. The concept of Hemafuse use, we're going to practicalize it in the concept of Ghana. And here we're inviting Dr. Gerald Osei-Owusu, who I've mentioned already, who has collected a case series of 4 different cases where this device has been used. Cases of ectopic pregnancy with complications that blood has been salvaged and used to successfully sustain the patient, and they are well at their homes as we speak this very moment. So let's give him a chance to explain what he did and all that happened during that process. So Dr. Gerald Osei-Owusu, you have the floor. Thank you very much.
Thank you. I'm Dr. Gerald Osei-Owusu with Tema General Hospital, specifically with the Obs and Gynae department. I would like to begin by sharing some series of cases where I got the opportunity and some of my colleagues to use the Hemafuse device for autotransfusion. So I'll go ahead and share my screen now. Okay, so to begin with the presentation, I've captioned the presentation, the use of Hemafuse for ruptured ectopic pregnancy, experience of Tema General Hospital. The outline of my presentation will be, I'll begin with a short introduction, then go ahead with the 4 case scenarios where I use the Hemafuse device, and later lessons learned while using the device. So, ruptured ectopic pregnancy is the second most important reason for emergency surgeries in our department. About 90 of them that come in shock. And averagely, we do about 4 ectopic cases surgeries in a week, which last year we had, 2019, we had a total of about 254 cases. And last year we had about 241. On an average, each patient after a surgery will need about 2 units of blood transfusion. Therefore, it's a big consumer of the hospital's blood stock. It's definitely a challenge getting donor blood for these transfusions. Just as Dr. Asma just does, this is the device we use for the hemotransfusion. That's the autotransfusion during the surgeries, which Dr. Asma did a good job by demonstrating how it's used. So to begin with the first case, which was done in September 2020, Madam E.T., who was 28 years old, gravida 5, para 2, alive 2, spontaneous abortion, which her last menstrual period was about 2 months before presentation. Urine pregnancy test was positive about a month prior to presentation. Patient was rushed in with a scan that suggested that with a diagnosis of ruptured ectopic. Patient complained of lower abdominal pain and was symptomatic of anemia. Patient had no known chronic illness. On examination, patient was pale 2 classes, though GCS was intact, still presented in shock with a BP of 90/40. On abdominal findings, there was garden rebound tenderness and chondrosynthesis was positive. The HB came out before surgery to be 5.7 and a blood group of O positive. An impression of hemorrhagic shock secondary to ruptured ectopic was made. Patient was resuscitated and taken to theater. In theater, we realized that there was a ruptured right ampullary gestation with a hemoperitoneum of about 1,500 mils. We did transfuse the patient with her own blood, that's the hemotransfusion. We used the Hemafuse device and we were able to salvage about 550 mils. And that's one of the pictures over there. After transfusion with the patient's own blood came up to about 7.9 7.1. Patient was discharged home on oral hematinics on the 3rd day, meaning patient was not given any donor blood. I move on to case 2. Madam Enkel, 39 years old, who was rushed in from a referral facility on account of hemorrhagic shock secondary to ruptured ectopic, which they resuscitated there before bringing to our end. Patient had no known chronic illness. On examination, GCS was 13 on 5. Patient was pill 3 pluses, though the cardiovascular system was stable. On examination of the abdomen was distended, yet moves with respiration, Parasynthesis was done and it was positive, meaning there was massive hemoperitoneum. HB done was 7 with a blood group of A positive. In theater, we realized that there was a left ampullary ectopic gestation which had ruptured with a total blood loss of 2 liters, that's 2,000 mils. Autotransfusion was done with the help of with the use of Hemafuse, and we were able to salvage about 1,000 mils. Post-op HB after 24 hours, we realized that the HB had come up to 8.5. Therefore, patient was discharged home on oral hematinics day 5. Patient did not require any donor blood. Case 3, Madam JB, 25 years old, came in complaining of a week's duration of bleeding PV. UPT done was positive, meaning patient was pregnant. Patient had no known chronic illness. On examination, GCS was 13 on 15. Patient looked pale, yet cardiovascular system was stable. On abdominal examination, there was generalized tenderness, rebound tenderness, signs of peritonism, meaning there was blood in the peritoneum. HB done was 7.7 and was a blood group of A negative. Client was rushed to theater, and in theater, we realized that there was a femoral ectopic gestation which had ruptured with a hemoperitoneum of about 850 mils. With the help of the Hemafuse, we were able to autotransfuse the patient with her own blood, 400 mils. Patient required no donor blood. Therefore, patient was discharged home with an HB of 8.5, post-op day 3 on oral hematinics. I would like to take the last case, Madam VA, who was 41 years old, gravida 4 para 3, also referred from another facility with a query ectopic. Just as we all know, sometimes diagnosing ectopic pregnancies can be a bit challenging. On examination at our end, patient complained of lower abdominal pain. UPT was positive, and patient had no known chronic condition. On examination, patient was conscious and alert, just pallor of 1+, yet cardiovascular system was stable. On examination of the abdomen, there was suprapubic tenderness. The abdomen was distended. Fluid thrill was positive, and chondrosynthesis was also positive. Therefore, we made an impression of a ruptured ectopic. And to our surprise, on the investigations, the HB came out to be 4.5 with a very rare blood group type, that's O negative. In theater, we realized there was a ruptured small ectopic gestation, and patient had lost about 1.3 liters, that's 1,300 mils of blood. We were able to autotransfuse her with the help of the Hemafuse device, 900 mils of her own blood. 24 hours post-op, HB had come up to 6.8. Yet, patient was not that stable, so patient required extra 2 units of donor packed cells, which we gave. Patient was discharged post-op day 5 because we had challenges getting a donor packed cells to transfuse the patient, so patient had to stay for about 2 days more to get this blood transfused. And patient was discharged home with an HB of 8.9 on oral hematinics. With this, I would like to share the lessons I learned whilst I use this Hemafuse device to help our clients. There are medical benefits, of which using everybody, just as Dr. Deganus said earlier, everybody would prefer to be given his or her own blood rather than another person's, because you don't know what infection might be in. Even though we know the blood are screened, but we know for HIV, we know there are window periods. So therefore, everybody wouldn't like another person's blood to be given if there is opportunity to receive his or her own blood. So autotransfusion with Hemafuse helps to reduce the risk of transmitting infectious diseases. There's also no danger of isosensitization. And we know that autotransfused blood has a better oxygen transfer and higher activity of the anticoagulation factors, because those blood stored loses all these characteristics. And for autotransfusion, we wouldn't need any pre-transfusion examination, as we do for people who would like to donate. There are cost benefits to the patient. There are cost benefits to the patient also, because just as we realized in the cases, the first 3 cases spent averagely 3 days in the hospital because we were not hustling for donor blood, which sometimes, most of the time, we realize in our facilities we are short of blood. We have to send patients' relatives elsewhere, which they have to pay for the processing. And this is from our end, Tema General Hospital, the charges for blood processing. And it is clearly stated down here, that the payments patients and patient relatives make are not for the sale of the blood. It's just for the processing of the blood. So actually, blood is not sold in Ghana. You only pay. So if there are no donors around, it's going to be a hell of a problem, even if you have your money. And the hospital also benefits from autotransfusion with Hemafuse. There's less demand on the hospital's blood stores, because patients are transfused with their own blood and wouldn't need to visit the blood stores to be given donor blood. There's also less cost to the hospital, because they have to go out to recruit volunteers, conducting various tests on the blood they are able to get, the cost that comes with the blood typing, cross-matching, and even storing and transporting blood to the appropriate facilities. There are other benefits, because the consumption of homologous blood is reduced economically, and in the case of some religious objective against hemotransfusion or transfusion of homologous blood are also eliminated, because we don't have to go through the ethical challenges of, say, the Jehovah's Witness who don't take donor blood. And this is an opportunity for them to receive their own blood, which they do accept. I think with this, I would like to end my short presentation here, and I hope you all agree with me that there are lots of benefits with the use of Hemafuse for autotransfusion, which I have personally experienced and has been beneficial to my patients and my facility. Thank you.
Thank you. Thank you very much, Dr. Gerald Osei-Owusu. This is a brilliant presentation, and to put it in context of the national scale, I will provide you with little information saying that annually we have about 14,000 cases of postpartum hemorrhage, out of which about 194 died. This is from the latest EMOC assessment. And when it comes to a topic, in this same 1 year period of the EMOC assessment, we had a total of 4,480 cases of ruptured ectopic cases that were managed, out of which the mortality index was around 0.3%. All these cases put a huge demand on our blood supply. And it is good to know that in Ghana, we rely heavily on replacement donation. That is where relatives and friends come to donate blood to replace blood that has been given. And in most cases, you might need a relative to donate before that blood even will be given to you, as against the universally or the World Health Organization requirement of about 95% of all blood from donations that are unremunerated. We've not gotten there yet, and therefore this intervention coming in as quite handy to reduce the burden on the use of blood products that we have in our facility. So on this note, I say, Dr. Osei-Owusu, thank you very much for this brilliant presentation, and I hope we all learn from it and we'll pick it and use it abundantly within our facilities. All right. On this note, we'll move to the next presentation, and we're talking here about the medical and ethical challenges relating to blood transfusion in special groups, especially the Jehovah's Witness. And to do justice to this topic, we have Mr. Fred Anim, who is a member of the Tema Hospital Liaison Committee of the Jehovah's Witness. He will take us through that, and at the end, we'll be able to understand and improve our acumen in handling difficult situations when it comes to blood and autologous blood transfusion. So, Mr. Fred Anim, you have the floor. Thank you very much.
Thank you very much, Dr. Fofie. Thank you all for the fine presentations we've heard. Indeed, we are very glad that we have the privilege to be part of this presentation. As we've heard in the previous presentations, some individuals would prefer not to have their own, to have another person's blood for many reasons, including probably medical reasons and personal reasons. But for Jehovah's Witnesses, as you see, our reason is primarily based on our religious stand. And as you can see, our stance presents a medical and ethical challenge for the medical practitioners. So this presentation is to capture some 4 objectives. But before we do justice to the 4 objectives, permit me to share these 3 slides that touches on the basis for our presentation, that there are issues related to cultural and religious diversity. And this slide from the General Medical Council highlights 4 key issues that makes each individual who he is differently. And that has to do with the person's personal beliefs, his values, his cultural and religious practices. And all these 4 key areas are central to you as a medical practitioner, and they are central to all individuals, including Jehovah's Witnesses. Now, this same point is presented in a different way by Sir William Osler, who is a physician and educator. In fact, most of you who know him know that he is one of the pioneers of bedside medical training. And look at the point he makes, that let's be objective in not just focusing on the special features of the disease, but then we should also focus on the individual. So it's a holistic approach. So if you are focusing on the individual, then you will not take out the 4 key things that we touched on. We will not relegate that to the background and focus on the disease. We will touch on the person's personal beliefs, his cultural values, his religious values, and the like. So there is a story of one patient who is a chief, and we know in Ghana the culture, chiefs who are probably maybe defective of probably a limb, even just a small part of the body cut off, are disturbed. So if this chief who probably has a recommendation that he has to get an amputation says, no, I will not want an amputation, the doctors respected his personal wishes and provided alternative treatments to meet his wishes. It's the same light that we are looking at the issues of Jehovah's Witnesses and our medical and ethical requests. Now, Baruch Spinoza puts it from the point of view of a philosopher that we want to understand patients. And we want to thank all you medical practitioners who have managed Jehovah's Witnesses for the understanding that you have shown and continue to show for our members. Now, what is the objective of our presentation? They are 4-fold. One is our position on medical treatment. Then, after we've talked about our position on medical treatment, what arrangements do Jehovah's Witnesses have to support their members so that they can receive quality medical care and meet their wishes fully. And how are Jehovah's Witnesses organizations supporting you medical practitioners so that you can manage our members and, of course, go beyond managing our members to manage all your patients with resources that relate to transfusion alternative strategies. These are the main presentation objectives. But first of all, let's look at what is the stand of Jehovah's Witnesses on medical treatment. As most of you are aware, you meet Jehovah's Witnesses in the hospitals because they are not anti-medicine. Jehovah's Witnesses do not refuse medical care. We encourage our members to seek quality medical care. In fact, since we are talking about obs and gynae, let me let you medical practitioners know that for our members, an arrangement has been put in place for our pregnant members so that they can receive care in such a way that the risks to which they are exposed to is reduced. As Dr. Deganus said, there are some individuals who must receive medical care in the hospital setting, those with hemolytic diseases. But Jehovah's Witnesses as a group, because of our refusal for blood transfusion, also fall into that category. So we request that when you have Jehovah's Witnesses pregnant women or Jehovah's Witnesses patients coming to you, we would request that because of their stand on blood transfusion, they must be managed as an at-risk group. And we help our members to do so by giving them information that is adapted from the WHO guidelines for pregnancy called the Healthy Mothers, Healthy Babies. We also share information with them. For instance, a recent document we are sharing with them touches on information for expectant mothers. One of them is for them to discuss with you, the obstetricians and gynecologists and antenatal team, that they are an at-risk group. So you may want to discuss with them the possibility of even hysterectomy right when they are in good mental frame of mind, so that that option may be considered in cases of postpartum hemorrhage. What Jehovah's Witnesses refuse is transfusion of blood. But then it doesn't mean we are refusing medical care. We want alternatives to blood transfusion. As you see in the picture down there, this is the kind of scenario that we usually receive from you medical practitioners. And we thank you for that, because you discuss the options with us. You tell us, if you don't want blood, these are the options. You discuss the pros and the cons, and our members select which option they prefer. This is what we want. That kind of collaborative, cooperative approach is what we want from you. Well, we are not here for a religious presentation, but this one slide highlights the reason why Jehovah's Witnesses refuse blood transfusion. Many scriptures talks about abstain from blood, and our members value that scripture and take it as it is. They want to have nothing to do with it. You see a number of Bible translations down there. They all say the same thing. But please take a look at this slide. This is the key points that we want to highlight. When we say that we refuse blood, let's look at allogenic blood, someone else's blood. So when you want to give our members whole blood, or let's say you want to give them the 4 major components, like let me give you packed cell, or let me give you the platelets, or let me give you the fresh frozen plasma, this is what our members will refuse, the whole blood together with the 4 primary components, as you see. However, let's bear in mind that in nature, certain processes take place. For instance, there is crossing of the mother to fetal system with albumin and other clotting factors. They happen in nature. So our stand on blood fractions is that individually make their choice. It's potentially acceptable. Please discuss with them. So some doctors, in place of fresh frozen plasma, have considered giving them albumin, which is an extract from the blood, protein extract from the blood that helps with clotting. Some clotting factors have been given, some fibrinogen and some immunoglobulins, even cryoprecipitates is potentially acceptable to our members. So there are options apart from fresh frozen plasma, and medical facilities that are considering this at-risk situation are planning with such products for them to be able to use, even in cases of, let's say, coagulopathies, or you have DIC. It is being used. Now, let us look at one scenario, autologous blood. As we had in the presentation, and as you see on the screen, if you suggest to our members that you want to take their blood, store it sometime before the delivery or before the surgery, when you come in and you have need for blood transfusion, we'll give your own blood to you. Because it has been removed and stored, our members will refuse that. But intraoperative blood salvage techniques are acceptable to our members. As we have seen, Hemafuse is a device that is a manual blood salvage device and is potentially acceptable to our members. They would want to make a decision that they would accept it, and we request that you discuss with our members before the surgical procedure. Also, some doctors and anesthetists are employing hemodilution techniques, normovolemic, hypervolemic hemodilution techniques, where some of the patient's blood just before the operation is removed, but they maintain hemodynamic stability by administering volume expanders. So that when the patient loses blood, he loses diluted blood. And then right after the surgery in the theater, the patient's own blood is administered to him. The difference with preoperative blood collection and storage is that the blood is not stored in advance and is potentially acceptable to our members. Now, some have asked that what if the patient is incapacitated, the patient cannot talk, and somebody else must make a decision for him? Our members carry this document on them. It states their name, states what they would not accept by way of whole blood or the 4 primary components. It states their medical history briefly and emphasizes that no doctor or relative can override their wishes, even in case of incapacitation. It is a legal document, so it is witnessed and signed by 2 witnesses, and the patient appoints healthcare agents and alternative healthcare agents so that in case of incapacitation, their wishes will be enforced by the healthcare agents. So no one can override their wishes. And you may want to request this document from our members when they walk into your facility. Now, how do we help our members to receive quality medical care without blood transfusion? So around the globe, Jehovah's Witnesses have hospital liaison committees. In Ghana, there are 18 such hospital liaison committees operational. These are volunteers who receive information that is of relevance to non-blood management strategies, and we share with you medical practitioners. What do? Medical articles are shared from well-renowned sources, and we share it with you medical practitioners. We also arrange doctor-to-doctor consultation. One doctor is managing a case. He feels that he cannot manage without blood. He would now request, maybe through the HLC discussion with him, can we get another doctor who has managed the case without blood transfusion? He says, I would like to talk to the doctor, and that is achieved. A recent case we handled in Aflao was interesting. The doctors were treating a bleeding non-pregnant woman. They wanted to transfer. They got the assistance from another facility where there is an obstetrician gynecologist who did telephone discussions with them. Case was managed in Aflao. No need to transfer. These are the kind of network supports that we do. We also assist in patient transfer when necessary. And of course, we make presentations to you medical practitioners just like we are doing now. We are available 24/7. At the end of the presentation, our contact numbers will be shared with you. Now, in the next 4 or 5 minutes before my presentation comes to a close, I want to touch on this. So we share resources with you clinicians, resources that have been published by your own colleagues across the globe, including Ghana. We have a dedicated department called the Hospital Information Services that collates all these resources and share them with you. There are 4 categories of resources. Now, since the world is going digital, we share information that is present on our website. We have a link dedicated to you medical practitioners, and we want you to get to know that and explore various medical information that have been published there. We also have clinical papers that we share with you, and we shall share some with you when you contact us through the phone number we provide at the end of the presentation. We also have evidence-based summaries. We'll show you what they are. Let me just quickly share the news slide for you to see what we mean by that. So as you can see from this new slide that I'm sharing, this is the link to the web-based resources. I hope you can see the link to the web-based resources. So for instance, if you just went to your search engine and typed in medical information for clinicians-jw.org, and we shall send the link to you, you would have access to the resources that we are talking about. It opens you to this link. As you can see here, there are very useful resources here. There is various subcategories here. We have the resources grouped under medicine and surgery, pediatrics, disease conditions, bioethics. You also have featured articles that represents the most current clinical study information on non-blood management. For instance, the recent one that has been published in 2021 talks about comparison of the 4-factor prothrombin complex concentrate with frozen plasma for management of hemorrhage during and after cardiac surgery. As you read this, you see that the 4-factor prothrombin complex is equally effective compared to fresh frozen plasma. So if Jehovah's Witnesses will not accept fresh frozen plasma, they probably would accept the prothrombin complex concentrate. Let's just explore the medicine and surgery briefly. I have clicked on the link, medicine and surgery. What do we see here? You have the contact of the local HLC representatives here. You have downloadable resources here, PDF and videos. Downloadable videos, as you can see on the right side of the screen. Now, let's say I'm interested in cardiothoracic surgery. I'll click on the link of cardiothoracic surgery. I'm interested in obs and gynae. Let me just open obs and gynae. This is the link for obstetric and gynecology, as you can see here. There are various links that gives you various articles under antenatal evaluation, anemia management, thrombocytopenia management without blood transfusion, inhibition or delayed of preterm birth, intraoperative autologous blood management, and you have blood salvage here. There are a number of clinical study articles that talks about blood salvage, as you can see me opening the link. And it shows that blood salvage techniques are very, very effective in obstetric and gynecology cases. These are some of the links. You will find the abstracts to the clinical studies here. You can click on that link and you have the information. Now, let's quickly touch on some of the resources that are evidence-based summaries. So, to help you medical practitioners who are managing our members and other cases without blood transfusion, let's say you want information, but then the question is that you probably will not be able to have time to go searching for all the information from various sources to manage our members. So what has the Hospital Information Services done? All these clinical studies have been collated at one point in this document. This is just about 12-page document. This document has over 500 clinical studies. The abstracts are what have been shown here. This is just the clinical studies. This is about 426 clinical study articles. The abstracts are what you see here. So what have we tried to do with this? Well, let's quickly have a look at the contents of these abstracts. As you see on the page 1, the abstracts have information on clinical evaluation, optimization of red blood cell mass, management of menorrhagia, obstetric hemorrhage. There's a very nice chart on algorithm for management of postpartum hemorrhage. Very, very beautiful chart that a number of hospitals have adopted as one of the strategies that they want to develop their own algorithm. As you can see here, algorithm for non-blood management of postpartum hemorrhage. Some facilities have had a critical look at this and have developed strategies for managing patients who may refuse blood transfusion. Blood salvage is also talked about here. And if you just searched blood salvage, you'll find information. So I'm just doing a quick search to end our presentation. Let's say I type blood salvage if you are using the soft copy. So as you can see, I'm typing blood salvage in the top right corner. I click on it and you have blood salvage here. It talks about blood salvage use in various scenarios. This includes in placenta previa cases, in cases like we've talked about, ectopic pregnancy cases. These are potentially acceptable to our members. So as we bring our presentation to a close, what do we say? We want to say that there are resources that have been collated for you medical practitioners at our links, and we will encourage you to make use of these resources. This is the link to the web-based resources. We shall share the link with you after the end of the presentation for you to have access to information from your colleagues on non-blood alternative management strategies. Now, these are some of the clinical study articles that we shared. And one recent one that I read talks about management of pregnant women without using blood transfusion. What are the strategies that some doctors have used? These are available for you to have a look at. Now, all these clinical studies are high impact factor clinical study articles, and they focus on the 3 points you see on the bottom right of the screen: avoiding transfusion with the use of pharmaceuticals, devices, and techniques. This is the clinical strategies I talked about. They come in surgery, critical care, obs and gynae, and GI bleeding. There are additional resources that you can download when you go to the web-based resources, award-winning video on transfusion alternative strategies, and then information on hospital liaison committee, religious and ethical position of the obvious witnesses, and the value of the clinical strategies. At this point, my last slide touches on what we propose that all medical practitioners consider when our members are involved. That there are appropriate transfusion alternative strategies. We encourage you to review them and use as much of them as much as possible for our members. You have a lot of medical practitioners who are experienced in managing some of the cases without transfusion. When one doctor says, I cannot manage without transfusion, from our experience, other doctors have managed the cases. Please contact the hospital liaison committee freely, and then if necessary, let the HLC assist in the transfer of the patient. Thank you very much for the time. I've used 19 minutes. I've gone 4 minutes over time. Sorry about that, but I hope the presentation has been beneficial. We would await your questions at the end of the presentation. Thanks.
Thank you very much, Mr. Fred Enim. That is a brilliant presentation. I think at this point, we all know the position of the Jehovah's Witness. They are not coming confrontational. They are not fighting us as practitioners. They are simply saying that they have autonomy. They want to be part of the care, and therefore they will be deciding and supporting us with resources, both monetary or even information, clinical, technical information that will help us to be able to give them the very best care that they deserve. So once again, Mr. Nim, we say thank you very much. At this stage, we move to the final step, which is the question and answer session. And it is good to specify that if you have questions, you can conveniently drop them in the box, the chat box, and we read them from there. I'll be getting some assistant to read the common questions there. And those who also wish to leave their hands on the app, we will be able to call you from this end. Now, this question and answers, as much as possible, we want it to remain clinical and technical. That is, the questions should focus on the 3 presentations that, or I'll say 4, that we've made, the 3 presentation and the case that demonstration that was made. So you can ask questions on that. Any issues related to the Hemafuse device specifically, concerning the pricing, concerning availability, yes, we'll say it's available in the country, but any further details on that, you have to contact our officers. And I think that is in the chat box already. Dr. Ajay will be handling that. So you can contact him and you get the full information. So as much as possible, let's put the questions concerning the presentation so that we can all enjoy them. At this point, I open the floor for the questions and start enjoying the moment.
The first question is in regards to for Dr. Gerald, asking if the Hemafuse is single use. So we may let Dr. Gerald jump in.
So the Hemafuse comes, so the question whether it's single use or not, it comes in 2 components. One component can be used 25 times, and the other component, which is disposable, is single use. I don't know if it's clear.
Yes, Dr. Gerald, it's clear. So the canister usually is for multiple use, right?
Yes,
the syringe-like structure, then you can use that various times. But the filter, which usually you use to separate the particles from entering into the canister or the syringe-like structure, that is a single use. And I think we saw that in the demonstration by Dr. Asma. So that is very clear, and I hope our participants are happy with the answer. Thank you very much. The next one, please.
The second question we have is for Dr. Deganus. Dr. Deganus, they asked if the treatment, the ULL treatment is folic 5 milligrams or 0.5 milligrams.
Okay. This is Dr. Deganus. The tablet we have is 5 milligram tablet, okay? But WHO is recommending a lower dose. That is a 0.4 milligram tablet for supplementation as adequate. So in fact, countries are being convinced to use the lower dose of folic acid. And this is particularly important when it comes to issues of folic acid and SP. There have been some challenges with that, but the recommendation is 0.4 milligram. But the tablet in town, which all of you are very familiar with, is a 5 milligram tablet. So that's what is available. But it's a big tablet, and we are gradually shifting to a lower tablet. For anemia in pregnancy, is the same dose, 0.4 milligram is thought to be adequate for managing anemia. The only persons we recommend the 5 milligram tablet is for those with the sickle cell disease. Over. Hope I've answered the question.
Thank you very much, Dr. Deganus. That is correct. And we're saying that the ministry and the Ghana Health Service is putting in effort to get the new consignment with some development partners labeled as 400 micrograms. That's the 0.4 milligrams. Yes, so 400 micrograms. So very soon we'll be getting that produced in country. So most of the folic acid that we have will be labeled as 400 micrograms rather than the 5 milligram, which is way higher than the recommended dose by the WHO. So that is correct. Thank you very much. Okay, can we move to the next place?
Yeah, the next question is for Mr. Fred. So Mr. Neem, the question for you is, how about if there's no durable power of attorney and patient is incapacitated?
Well, if a patient does not carry a durable power of attorney, it is only reasonable to expect that the medical practitioner will do what is best practice as far as his training and the hospital protocols are concerned. For instance, if a patient has a durable power of attorney, but in a medical emergency like a trauma, the patient probably lost his durable power of attorney from his pocket, or let's say in a situation where the patient failed to carry it, then there's very little that can be done about it. But with the regular training of our members, we encourage them to carry it wherever they go. And when they go to the hospital, we encourage them to place one in their medical folder and discuss with the doctors well before a critical situation comes up. And most of the time, they do so. It has been very helpful. We've had cases where a patient way back in a different region had an accident, and then the healthcare agent has been contacted because they found the DPA in the person. So we encourage you, medical practitioners, when you have any Jehovah's Witness, request for the for the DPA. Request for it. Let me share one interesting story. In one hospital where they consistently request that patients donate blood before they are admitted for deliveries, Jehovah's Witnesses are not required to do so by hospital protocol. And one doctor said, oh, sometimes people come here and they say, oh, we are Jehovah's Witness. Then we request, where is that paper? Where is your paper? Of course, they don't know the paper they are talking about. It's available to our members. So the DPA is a valuable document, and it helps you, the medical practitioner, to treat the patient according to his wishes without any fear of any adverse outcomes on you, because it's an adult who has made an informed choice and documented it.
Good. That is an excellent answer you've given. This bordering on medical ethics, right? Medical legal issues. If the document is available, you go by the document. If it is not available, you go by the prevailing medical standards. Thank you very much. We move to our next question, please.
Yeah, I think for the next question, Dr. Fofie, we can call on somebody by that their Zoom name is Huawei Y6 Prime 2018. Feel free to unmute yourself. You've had your hand up for quite some time and ask the question.
Miss John Mason.
Good.
I want to know, with the Hemafuse, would they take the patient's blood and increase it with medicine, and at the same time they give or it's only medicine that they dilute and give? Thank you.
Thank you very much.
So the whole concept is we don't mix any medication. It's just like taking a syringe to pull the blood in the patient and later giving it back to the patient. So we don't mix it with, the only thing we mix it with is the anticoagulant so that the blood does not clot. That's the only thing. We don't mix with any medication. So we are just collecting the blood from the patient's abdomen, putting it in the blood bag. The blood bag contains anticoagulants so that the blood does not clot, and we re-transfuse the patient. And it's just as simple as that. Thank you.
Good. That is straightforward. The answer has been given. So we can move to the next question, or if there is any follow-up.
We have somebody that has labeled themselves as me. You've been unmuted. Please go ahead.
Thank you.
Introduce yourself.
Thank you very much. My name is Emmanuel, and a health practitioner and also a Jehovah's Witness.
Good. Emmanuel, go ahead.
I want to find out whether Hemafuse, does transfusion take place at the same time as the collection of blood during the procedure or after the surgery?
Okay, so it's done intra-op. We collect the blood, we keep it. Immediately we seal where the leakage is, whatever the problem is. We start transfusion in theater. We just have to make sure we repair where the problem is before we start transfusing, because if we don't seal it, it will just be like fetching water in a basket. Everything will drain back. So we have salvage the blood in a blood bag. Immediately we finish repairing whatever the problem is, whatever is causing the bleeding, we just start transfusing in theater before we even finish the surgery.
And then Dr. Gerald, can you expand on how long the blood that is collected is viable for transfusion after collection?
Oh, okay. Normally, we try and use it within 30 minutes. We try and transfuse it within 30 minutes.
Right. And then you have up to 6 hours after collection.
6 hours, yeah, after, yeah. 6 hours.
Exactly.
Yeah.
Exactly. All right.
Good one there. So let's move to the next one. I hope, Emmanuel, you are happy with the answer. You know it's not going to be stored in any fridge. You're going to get it immediately or at most 6 hours after it has been given. So that's good. Yes, let's get the next.
The next question is from Nana Ama Densoa Pepra.
All right. My name is Stephanie Nana Ama Densoa Pepra. I'm a midwife. And then my question goes to Dr. Gerald. I want to know that we have pregnant women like defaulters because of some condition, let's name like HIV positive. And then when they come in the final trimester, or sometimes they come in labor. So with this special clients, we know we have a problem with the HB because of their condition. How are we going to manage this patient? Are we going for theater or what? Because with the hemotransfusion, we know that with the theater is the best way. How are you going to manage such patients without blood? Thank you.
Yes. The question is whether you have a pregnant woman with severe anemia and coming into labor, and what are you going to do? Are you going to transfuse with Hemafuse? I think it's straightforward. What we said is if we can, no pregnant woman should enter her third trimester with anemia. If you are looking after a woman for so many months, there is no reason for her to come to labor with anemia. However, we live in the real world, and there are women who are going to show up with anemia. And I did say that we have very little choice when they are that severely anemic and very symptomatic. The option is to transfuse them. The Hemafuse is for autotransfusion, salvaging blood that has pooled somewhere, like in the abdomen. Unfortunately, there are some conditions that must be met. You must avoid blood that has been mixed with liquor. So you cannot transfuse blood that has liquor in it. That is dangerous for the woman. So unfortunately, Hemafuse is not very it's hardly usable in labor and during cesarean section to salvage blood. And that is a very difficult choice when you have a woman with severe anemia. The other option is to give her blood transfusion. I hope I've answered your question, but maybe I don't know if I did answer it to what your satisfaction. Over.
Yes, Dr. Deganus, I think you also touched on another point, which is another question we've got. So maybe I'll ask a follow-up to yourself and Dr. Gerald here. There were two questions. One was, is there any concern about amniotic fluid or any foreign matter introduced into the intravascular space during Dr. Gerald's case with ruptured ectopic? So maybe Dr. Gerald or Dr. Deganus can talk about if there's any risk about amniotic fluid or foreign matter in the intravascular space in ruptured ectopic to start.
Okay, so I would like to start. So basically for all the cases for the ectopics we used, it was not used in very advanced gestation because advanced gestation means that the amniotic fluid, we have enough amniotic fluid, which we don't want to retransfuse into the patient because there's a likelihood of causing an amniotic fluid embolism. So for all the cases, they were not really advanced gestation, less than around 12 weeks. Thank you.
Perfect. Yeah, great answer, Dr. Gerald. And I think maybe another one for you, Dr. Gerald, is we were asked if Hemafuse is only in cases of ectopic, ruptured ectopic.
Okay, so not only in ectopic pregnancies, we wish we could get the opportunity to talk about the indications for the use of Hemafuse. Just as I think Tim mentioned it, we have other indications in aortic aneurysm, cardiac surgeries, where in any surgery or in any case where there is accumulated blood in the body, we can salvage that blood, provided it's not contaminated or does not have any other contaminants in. Thank you.
And Dr. Gerald, how would they know about some of these indications and contraindications? How could they get a training on this sort of device?
Okay, so we are, my boss is here, Dr. Deganus, myself, and some other people. Any hospital or any facility that are ready, we normally go around with organizing workshops. And in the process, we talk about the contraindications, the indications, and we have hands-on practice workshop on how to use the device. And it's very brilliant, it's very hands-on. You get the opportunity to learn it at first hand. Thank you.
Please, may I make one point about a case that a doctor mentioned concerning Hemafuse use in Comfort Noche Teaching Hospital? Can I share that, please? I had an opportunity to talk to one doctor in the, Hemafuse is currently being used in some hospitals in Ghana. So I contacted one doctor who mentioned it, and he said that the device was used for a cardiothoracic chest case where blood had pooled in the pericardium. And it was after the patient had a gunshot wound, and they used Hemafuse in that one case in Comfort Noche Teaching Hospital for a hemopericardium case where the blood was not in the abdomen, the peritoneum, but in the pericardium, and it was successfully used in one case. So it's up to doctors in other fields who may want to consider it, and we are happy that doctors would think of that option as auto-salvage, saying sometimes when the HLCs talk about auto-salvage, sometimes the medical practitioners are thinking of very huge equipment, automated equipment, expensive, need specialized practitioners, perfusionists to operate. But we think that this simple device is potentially acceptable to our members. It doesn't need expert persons to run. I don't know, maybe Dr. Osei-Owusu can talk about the constituents of the 3 persons which Dr. Asma mentioned who will be needed. I don't think all of them should be nurses from the way I see it. You could have people who are not nurses. I stand to be corrected. But we find this very exciting. Please, before it ends, let me mention that Tim, if you can later on put my number again so that we can send all the presentation material that we have to all those who are here. Contact me by WhatsApp on the 024 number, I am willing to send the presentation information that we received to you. So please kindly write that number again, because some of you would like to receive the presentation materials on the HLC and then the clinical strategies, the links. My number is there. Please write it now. Send me a WhatsApp. Just say transfusion alternative strategies in the WhatsApp. Please give me your name, your facility if possible, and then your specialty, and I'll send the information to you. If you want information about Hemafuse, please, I think that Dr. Ajay's number is there. You can contact him. But of course, since they've given us a fine platform, Dr. Ajay, if all contacts come to me on Hemafuse, rest assured, I'll be kind enough to pass on the contacts to you too. Maybe it will be easy for them to reach the Ghana number, 0244 645 179. We want to be able to reach out to all you medical practitioners who have contacted us. We shall arrange for the HLC in your locality to contact you and share more information with you. And I'll definitely gladly, out of respect for the opportunity given us by CISU, to pass on your contacts to the CISU person, Dr. Ajay, so that he will follow up with you on CISU medical device training, as they've written, the pricing and all of that. We'll be expecting your WhatsApps right after the presentation. Thank you.
I think we'll go to Seth Kunta from Tamale HLC. Seth, you go ahead and unmute Dr. Fofie. We've got Seth Kunta.
Yeah, thank you very much for the opportunity. As mentioned, my name is Seth Kunta, Tamale HLC, also a healthcare provider. I have a little concern, which I think maybe Dr. Deganus can address it. That has to do with the mothers for ANC cases. Usually at the lower level, like chiefs, health centers, most times the request that they make is HB. But from her presentation, and as we know, the full blood count is usually the best, as it elicits a lot of information for us. So I don't know what can be done, especially the midwives who handle the health centers. My question.
Hello?
Hello, so this is Dr. Deganus. Yes, I did say that the best is the full blood count because it gives you a lot more information about the hemoglobin and even sometimes what is underlying the low hemoglobins if you have anemia. But if you cannot do the full blood count, WHO says the next best is to do just the HB. And so don't worry that you cannot do full blood count. The HB is good enough. The problem we have, I think, is not that women are not doing the HB. Like I pointed out, what is the information being used for? I showed a chart to say that we are having about 30%, 33% of women having anemia at booking. That is when they walked in to start antenatal care. But we are still finding that even when they are in their third trimester, they are still about 30% with anemia. So there's something definitely not going right. Because if we are managing them well, then we should get as close to zero, as we can. We shouldn't have the women still being anemic at the end of their pregnancy, especially because they are coming for antenatal care. And that's why I raised the questions, what are we giving to the women? Are we really treating anemia? Are we doing it as we are supposed to do? So HB is good enough and it will do the job if you use it rightly. Over. Thank you. I hope I have answered your question.
Yes, thank you very much. Yes. The next question, please, team, if we have any. I think now we've dealt with quite a number of questions.
Yeah, maybe we'll do three more here. We'll let the Akorli family, who has had their hand up for quite some time, ask. Okay. Next will be the Corley family, then Ilove Obeng Omoako, and then we'll have one last question that was written in to end.
Good.
So go ahead, Corley family.
Yes, please, Akoli.
Okay. Thank you very much. Good evening.
Good evening.
I'm Emmanuel Akoli, a medical practitioner, also a member of the HLC. Please, my question, I think I'm going back to the Hemafuse and then the issue of amniotic fluid embolism, for which it cannot be used for CS cases. I don't know, in the presentation, the demonstration, Dr. The lady doctor, I forgot her name.
Yeah, Asma.
Okay, Asma, yes. When she was putting together the setup, I saw our header mention a filter, which was part of the components. I thought the filter was supposed to function to filter out anything that will cause any problem after the transfusion. So I don't know what component of the amniotic fluid is it that if it gets into the circulatory system will go to cause problem. Is it a fluid part? Because I know the blood contains fluid anyway. So I am a bit baffled as to why with a filter it cannot take care of that problem.
Good. Yes, this is a brilliant question, and I think if the presenters will allow or attempt to answer that, it's very possible that in the very near future this could be used. But with the information available now, we're seeing there is a filter which technically acts as a barrier that will prevent bigger particles like clots getting into the canister and therefore into the bloodstream. However, there is no way to ascertain that fetal particles which are allergenic are capable of starting embolism within the human body. There's no way to guarantee that that will not cross this particular filter. And for that reason, it's not recommended for that use. As at now, what we are sure is that if it's just clear blood collected from the abdomen, like in an ectopic situation, little particles that could be clots and things like that will be prevented from getting into the canister and therefore will render them safe. So it's very possible research continues and we might be able to develop this further and get a type of filter where we can guarantee that amniotic fluid or even fetal particles, including lanugo, hair, and things like that, that could start such processes in the mother can be separated. And when that day comes, that use will be made public. Until then, I think it's quite safe to accept what is available now. I don't know if other colleagues have more to add to this. Dr. Deganus, if you want to veer into it, Dr. Osei-Owusu or any of the other presenters. Thank you.
This is Dr. Deganus. You've said it all. You have Venice, you have lanugo hairs. They are all potential causes of thromboembolism. That's why we are not using it, and the evidence does not support its use. So I don't think there's anything else to add on.
Thank you very much. Okay. So the next on our question list, please. You
yes. Mr. Omoako, Dilove Obeng Omoako, please, you should be able to unmute yourself now.
Good, Mr. Omoako, we're waiting for you.
Please, it's Mrs.
Mrs. Thank you very much.
Please, to Dr. Deganus, I wanted to ask, in your presentation, you made mention that tea is one of the causes that reduces absorption of ions that pregnant mothers take. I wanted to find out whether amylose, because mostly, some people tolerate it a lot, or is it some category of tea, that is the coffees and then the ones with caffeine that you were talking about, or generally tea? Then my second question too is about the helminthes, that is the WMS. Please, is it safe after first trimester to deworm maybe twice till the whole pregnancy. And I wanted to find out, because some people naturally, especially with those who are used to deworming every 3 months, whilst not pregnant. So like in second trimester you deworm, and then third trimester too you deworm. Does it have any problem, or the whole pregnancy you have to deworm once? I wanted to know about that one too. Thank you.
Okay, so let me start with the last question, which was on the deworming. The recommendation is just once during the pregnancy and not twice. So I cannot suggest anything other, just a single episode of deworming. I think the first question had to do with, I've forgotten. Can you remind me, Dr. Fofie, do you remember?
Yes, please. He's asking about the tea that was mentioned.
Whether we could have Milo. And I know in Ghana, everything is tea, coffee tea, Milo tea, and coffee, that. So what we're talking about is the theophylline and the caffeine. I think those are the ones that inhibit absorption of iron. They bind to iron. I'm not too sure about theobromine. Theobromine is the content of cocoa. I've not heard about it being a binder, but I could check that. But it's the theophylline and the caffeine in coffee that we are talking about. They bind strongly to iron. And so if you take iron with that together, you will not be able to absorb the iron. I hope I've answered the question. And it's not just me. I showed a few things that also can inhibit iron absorption.
So I think Samson posted a point in the chat about that tea contains tannins.
Yes.
The tannins also inhibit absorption of iron. And then let's also not forget the antacids that are given to a pregnant woman to manage dyspepsia. It's also one of the biggest challenges that that would end up having the patient start anemic and pregnancy anemic. So the antacids, it's all about counseling. When to take the antacids and when to take the hematinics. So there's a whole range of products that will cause this problem. And Dr. Deganus mentioned the common sherry that the pregnant women eat. It's one big problem. The tea, the coffees, and then the milks also have another problem with that. So it's all about the timing of the intake. You take your hematinics and wait at least an hour or more before you take those products, and then you avoid food-drug interaction.
Okay, so I hope we've answered her question. Thank you, Fred. Yes.
As a holistic team, I think the question has been well answered. And I also add that if you take your hematinics with vitamin C, that also potentiates the absorption, and that could be helpful. Thank you very much. So now we go in for
with orange juice, Dr. Fofie. WHO says don't multi.
Not orange juice or guava, any juice that contains vitamin C.
Vitamin C. Yes.
Great. Thank you very much. So at this point, we are going in for the last question, and I hope we all enjoy it. So please, the floor is open.
The last question we had is, how do you sterilize Hemafuse? Is it by, how do you sterilize Hemafuse? Dr. Deganus or Dr. Gerald, do you want to answer that?
I'll let Dr. Gerald do that.
Yes, Gerald, we're listening. How do you clean the equipment? How do you sterilize? How do you make sure that between one use and the other, we don't get...
So let me just go over again, just as we said, there's a reusable components which can be used 25 times, and the other part is disposable. So for the reusable part, you have to autoclave it, but yet just like any other surgical instrument, you first decontaminate first for about 10 minutes. In the decontaminant, you wash it with clean water, you wrap it, and then take it to the CSSD for autoclaving. So that's how it's done. It's autoclaved.
Yes. Thank you very much. All too soon, we've come to the end of it. It has been amazing to have so many presenters, and I'll start with Dr. Deganus taking us through the entire management and handling of anemia. And if we don't remember anything at all, you should be able to go back with this information that no woman should get into labor with anemia. And therefore, she has given us tips on what to do, how to prevent anemia, the hematinics to give, how to prevent mosquito bites and all that. At the end of it, we are sure our mothers will get to term with HB above 11. And that is thanks to Dr. Deganus. We move on to give thanks to Dr. Asma Awad, who has given us a pictorial image of what happens really with the Hemafuse. Initially, we thought it was like a science fiction sort of thing, but he has simplified it. We can imagine it in our mind now. We can see it, and we feel confident that that same device, the same way she handled it, most of us in our community will be able to do it. And we are ready to push our medical directors to get some for our facilities so that we'll be able to use it. So that is good, and we say thank you to Dr. Awad. Dr. Osei-Owusu has simplified it. He has given us a clear idea that we can all do it. We can handle it. We can harvest the blood that has been potentially lost. What was going waste, he has recovered some, and we see clear percentages. When the loss was about one liter, he was able to harvest or at least recover about 500 mils. When it was about 2 liters, he recovered. So about 50% of the blood that was being lost at every situation, he was able to harvest it. And we look forward to others improving the technique as much to be able to harvest as much as possible so that at the end, none of our cases will ever need any blood from our blood bank. And that, I say, is a big step to help the national drive in terms of preventing maternal mortality, improving hemorrhage and all that. So on that note, I say thank you to Dr. Osei-Owusu as well. Now to the end of it, we have Mr. Anim, who made a general presentation of the concept of Jehovah's Witness in healthcare, making us to understand that they are not there to fight with us, they are not to compete with us, they are not neglecting healthcare, but rather they are coming in as equal partners and holding us by the word. They're saying that autonomy should be respected. So whatever they want, they are taking a step to write that down into a document. So once they tell us what they want, we have to respect that. And they are ready with a lot of support in terms of literature, all that, so that at the end we can up our game to be able to support them and save them, so that they don't die just because they are Jehovah's Witness. They live and thrive to worship their God. And that is the hallmark of a good practice within our country. The question and answer section has been brilliant. We've had questions from all areas, most of them focusing on Dr. Osei-Owusu, our star presenter for the day. And I congratulate him, and I think the questions have been answered perfectly well. To end it, I'll say that we all know the number of Dr. Ajay has been made public. So if you have any further question, and Mr. Anim, further question about how to get Hemafuse device, how to organize training, whatever you want to do, you can contact him and that will be done. So on this note, I say thank you very much, and also to the presenters for making this possible this evening. So we call it a close here, and I say thank you once again.